So my topic is percutaneous treatment for sinus venosus ASD, which is a rare form of atrial septal defects, perhaps 5% of ASDs. And in this condition, you will see that the defect is quite high in the septum, where the SVC overrides the left and the right atrium. The pulmonary veins come in at the back of the defect, and so it's like a four-way crossroad between left and right atrium, SVC and pulmonary veins. You get a large left to right shunt, and for years the surgeons have been able to put a patch in there and correct the defect. But more recently, perhaps in the last 6-7 years, transcatheter stenting has become available, and as you can see, the covered stent, it's much bigger than a surgical patch, admittedly, but it will close the defect and allow the pulmonary veins to drain round the back of the stent into the left atrium. And by doing this, you can achieve the same thing as surgery, but without stenotomy, cardiopulmonary bypass, and we believe avoid some of the surgical complications of operating in the area of the sinus node, narrowing pulmonary veins, or the SVC. But not all anatomy is favorable. Here you have a very high pulmonary vein coming into the SVC, and in this situation, we would, rather than divert this vein, allow it to continue to drain through the SVC, whereas diverting the major veins. If you use too long a stent, you will end up blocking this vein, and that's not something we want to do. I have to say, the veins that we leave behind tend to be ones where most surgeons would say they can't divert them, and they would leave them behind. Then again, perhaps even more challenging is the veins that are not quite as posterior, but slightly more anterior or slightly higher in the SVC. And what you don't know is when the stent goes in, the vein opposite the defect will be diverted. But what happens to this vein? Does it drain well behind this SVC stent, or will you end up narrowing it? And that's something we would want to avoid. So what are the requirements for stent implantation? You need to stick your stent in a non-stenotic distensible SVC with an adequate length so it doesn't embolize. Ideally, you flare it into the azygos or innominate vein to stop the stent moving. It needs to be wide enough to seal the defect at or just below the SVC-RA junction, and can be as much as 34 millimeters. And when you dilate stents to this diameter, you may get shortening, which can leave a gap. And the critical thing is to avoid compromising any pulmonary venous return to the left atrium. You do not want pulmonary stenosis at the end of this. So this is an example of an ideal case, a man with a big shunt, and I'll show the, if it will play the, this is a 3D reconstruction of his CT. You see the SVC draining towards the right atrium, but with a communication to the left atrium. And you can see the pulmonary veins coming in at the back. And when the stent goes down, these pulmonary veins drain into the left atrium. So how do we do the procedure? To test, we first do a transeptal puncture so we can put a catheter in the pulmonary vein, leaving a sheath in the left atrium, and that allows us to get simultaneous pressures between the left atrium and pulmonary vein. We blow up a balloon in the SVC-RA junction, inject dye in the SVC to make sure the balloon is fully sealing the defect, or the SVC and the defect, and then we inject contrast in the pulmonary vein, and here you can see an injection in the pulmonary vein drains directly to the left atrium with nothing to the right atrium and no obstruction. And if we look in the lateral view, importantly, you can see, although there's a bulge on the balloon, the pulmonary vein flow is unobstructed. Now, in doing these, we get the chance to have some fun with the hemodynamics. We don't always do hemodynamics in this way, but here you see the right atrium in yellow, the pulmonary vein and the left atrium, all simultaneous, identical pressures with the defect open. As the balloon inflates, you'll see that the pulmonary vein and left atrial pressures rise because the shunt is occluded. And in fact, they can rise quite spectacularly, but they go together, there's no gradient. And at the same time, the right atrial pressure falls, meaning the shunt's been eliminated. We do echo at the same time. You can see a laminar flow from the pulmonary vein into the left atrium. And when you look at your Doppler trace, you have a normal Doppler trace. And this would predict a good stent result. And here you see a stent implanted, and it looks a good position, but there's a small shunt at the bottom. You can see a shunt at this level. And by flaring the stent lower down in the SVC, you can completely abolish the shunt. Notice how there's only a tiny bulge on the stent here, but the pulmonary vein is completely unobstructed. And I'd call this a perfect result. Before we had the longer stents, we found that when we would dilate the stent at the bottom, the stent could sometimes be a little unstable. Here you see the stent has migrated away from the SVC. Fortunately, we have a long sheath that we can then push the stent back up, and then through a jugular vein implant an anchor stent, and that allows the stent to be stable, good flow through the SVC into the right atrium, and good flow from the pulmonary vein back into the left atrium. However, I mentioned these stents shorten. Here you see a 7-centimeter stent, but a very wide SVC. There's a small shunt when you inject in the pulmonary vein. The stent is dilated again and again. There's a tiny shunt, and after further dilation, you can see how long the stent was before and how short it is after. The other important thing to notice is only less than a centimeter attachment to the true SVC, and not surprisingly, the stent was in the right ventricular outflow tract a few hours later, and our surgeons had to retrieve this and correct the defect. This was patient number 20 in our series, and I just worry what would have happened if this was patient number 1. Would we have actually continued with the procedure? Would we have been allowed to continue with the procedure? This is an example of a patient with a previous surgical repair. You can see pulmonary vein angiography with a shunt across into the SVC in the biplanes. Patient has a moderate shunt, and this we again test with a balloon inflated in here. You can see now the pulmonary vein flow is diverted into the left atrium. There's a tiny shunt left. The balloon is not quite low enough, but after stent implantation, you just get perfect flow from the pulmonary vein into the left atrium. This is where it gets tricky. Here you have a patient where when you inflate the balloon in the SVC and inject in the pulmonary vein, you notice the dye hanging around in the pulmonary vein, and there's only a thread coming back to the left atrium. So much so that when you look in the lateral plane, you can hardly see any flow into the left atrium behind the balloon. When you use a slightly smaller balloon, you will see now you can get some flow into the left atrium, but dye still hangs up in the SVC, in the pulmonary vein. And when you use a smaller balloon, you now get good flow into the left atrium, but you've got a leak. So one would imagine that somewhere between 22 and 26 is the correct diameter. Again, the hemodynamics are really interesting. Here you have all the pressures the same. When you have the big balloon in there, you can see the right atrial pressure falls, the pulmonary atrium and left atrial pressure go up, but there's a huge gradient across that pulmonary vein, and you do not want to leave a stent there. And on Doppler, you can see there's only a thread of a pulmonary vein that's left behind, and continuous flow in the pulmonary vein Doppler. When you use the smaller balloon, there's no gradient between pulmonary vein and left atrium, but notice the right atrial pressure hasn't fallen. And that's because you're left with a shunt. And again, the echo is very helpful here. We can see unobstructed pulmonary vein flow, but a reasonable shunt. So in this patient, we use something we call pulmonary vein protection. And I like to look at it this way. This is showing the pulmonary vein going down to the left atrium, the SVC communicating with the pulmonary vein here. And you can imagine a stent blowing up here would actually obstruct this pulmonary vein. If, however, you put a balloon in the pulmonary vein and keep that inflated while you deliver your stent, you can see how you can mold the stent to stop the pulmonary vein being occluded. And so here's an example. We've put a balloon through the transeptal puncture across the pulmonary vein SVC junction, and when the stent goes up, there's a little indent in the stent, and further inflation of the stent, again, you get quite a nice indent here. And so the injection now shows unobstructed flow into the left atrium. There's still a tiny leak here. which I think will go when the LA pressure starts to fall again. But you can see the pulmonary vein is completely unobstructed. And again, if you look on the pressures, now you have a fall in the right atrial pressure, pulmonary vein and left atrial pressure rise together, and the echo shows good pulmonary vein flow with a tiny leak left behind. What do we do with the high pulmonary vein? Here you have the medium level pulmonary vein, and here you have a very high pulmonary vein. And when the test balloon is inflated, you can see this pulmonary vein is obstructed. This vein is almost at the level of the innominate vein. Again, I would say the surgeons would leave this behind. Of course, there's always one who will say, I can divert all the veins. So what we do here is we put a hybrid stent on. The inner stent is bare metal at the top end, and the lower end is a covered stent. We've protected the pulmonary vein just to prevent a bulge at this level. And now, when you inflate a balloon at the bottom end of the stent and inject, you can see that this pulmonary vein coming up almost at the level of the innominate is unobstructed. So you're not going to occlude this pulmonary vein. And the lower pulmonary vein then flows into the left atrium in an unobstructed way. What about pacing? I put this in for Jan because at the moment it's all hemodynamics. So here's a patient with a sinus venosus ASD who's had a transvenous pacemaker put in and then sent to us for correction. And it looks like you have a lead in the right atrium and one in the ventricle. The lateral shows this lead has actually gone through the sinus venosus defect into the left ventricle. So during this procedure, we extracted both leads, implanted a stent, and then put the new leads through the stent so they would automatically go into the right atrium and to the right ventricle. So what are the results like? We've tried to do MRI scans of these patients at a year after the procedure, and you can see the QPQS falls spectacularly, the right ventricular end diastolic volume index falls, and the right ventricle to left ventricle ratio falls, as you would expect and hope. So what are our results? We've done 50 patients now in the last 7 years, aged from about 15 up to 70s. We've had bilateral SVCs in 10 patients. We've protected the pulmonary vein in 14 patients. One stent embolized before discharge, as I said, patient number 20. So we've done better. The first 20 had one embolization, the next 30 didn't. We're holding fire, not holding our breath too much about what will happen. We've had one patient needed to be restenting for a residual leak. But follow-up from 3 months to 7 years, the QPQS falls from 2.5 to 1 to 1.2 to 1, mainly due to the occasional residual upper pulmonary vein we leave behind. And the right ventricular end diastolic volume falls to normal from 154 down to 96. So the conclusions from this is that interventional closure of sinus venosus ASD is possible in at least 3/4 of patients. There's a low incidence of residual leaks. You've only had one needed restenting. No sinus node disease, no SVC or pulmonary vein stenosis when we select the patients and deliver the stents in the way described. Obviously avoids morbidity of stenotomy and bypass. Stent instability is a concern, but now that we use longer stents or have an additional anchoring stent shouldn't be a problem. And it's always important to look after the pulmonary veins, whatever you do. Thank you very much.